All right, and last but not least, we have Elizabeth Thompson, who's a pediatric cardiologist and a critical care fellow at Duke University School of Medicine. And she's going to talk about human milk transfer and infant exposure to sertraline and a project that she's been working on.
All right. Thank you, Dr. Chambers. I'm excited to be here to talk today about a project that I've been working on for the past year or so, looking at human milk transfer and infant exposure to maternal sertraline. No particular disclosures, but I did want to acknowledge the MPRINT Hub opportunity pool that's funding this, which also allowed a collaboration between the PTN, UCSD, and a couple of funding mechanisms through the NICHD. So despite the benefits of breastfeeding, I think that we all know the perceived risk of prescription drugs is a barrier to breastfeeding. So a lot of these stats we've seen before, but over 1.5 million lactating women in the US take prescription drugs. And, we've touched on LactMed, we've touched on a couple of other really awesome resources that are out there, but really only 2% of these drugs have adequate safety data for use in lactation. So this graph here on the left shows the percentage of infants receiving any in the light blue line and exclusive breastfeeding in the dark blue line during the first year of life. And we're doing, a better job of getting women to start breastfeeding at about 80%. But, by 6 months, which is what ACOG and the AAP recommend as exclusive breastfeeding, really only a half of infants are getting breastfed at that time. And then this graph here on the right looks at breastfeeding rates over time based on maternal medication use. And this is from a study that actually was counseling women on breastfeeding. And over about the first year of the baby's life, those who were taking medications are, less likely to breastfeed over time. And so in addition to trying to encourage breastfeeding, one of the ways that we can do this, particularly in moms who are receiving drugs or taking drugs for their health, is to get better safety data to make informed decisions. And so one of the particular disease areas that is interest of me is perinatal depression. And particularly for this talk, since we're talking about lactation, I'll focus on postpartum depression. But it's common and it occurs in up to 20% of women. And we know that untreated depression can have devastating effects on the mom and the child. So things like poor maternal-infant bonding, lower infant cognitive and developmental skills, and increased risk of death, particularly for moms who have severe depression, being more than 6 times more likely to die by suicide. And so trying to weigh the risks of what are the risks of untreated depression with what are the risks of a medication and what are the side effects of that is really important for lactating women. And so the American College of Obstetrics and Gynecology, particularly for perinatal depression, recommends psychotherapy as first line, but then also recommends SSRIs as first line pharmacotherapy for severity levels that are refractory to psychotherapy or for more severe depression. And particularly inclusive in that is sertraline. And additionally, they also recommend against withholding or discontinuing medications for mental health conditions due to pregnancy or lactation status alone. And that might be hard to do in women who are, again, looking at there's not a lot of data for continuing this. And one of the important things is that there isn't a lot of data for it. So the effects of sertraline treatment on the infant are poorly characterized as well. There have been some case reports of serotonin toxicity, particularly in preterm neonates. There's been a couple of case reports or some smaller PK studies that have shown the maternal or the infant relative dose of exposure is about 15% of that for mom, but that's also ranged down from being undetectable as well. And then the long-term developmental effects of the baby being exposed to sertraline versus the baby being exposed to a mom who has untreated depression are largely unknown. And one of the reasons that we don't have that characterized well is that the maternal sertraline dose infant exposure relationship is inadequately characterized. And so I like to think about this in 3 steps. So first, we need to know how much drug is getting into the mom's blood, how much of that drug is getting from the mom's blood into the breast milk, and then how much of that breast milk is getting into the baby's blood. And so a couple of things that we do know about sertraline PK is that it has pretty slow absorption. The peak levels are being reached anywhere from 4 to 10 hours. It can last for a long time. It's a half-life about a day. It's metabolized by a lot of different CYP enzymes, and then it does get metabolized into desmethylsertraline or DMS, which is an active metabolite. It's highly lipophilic, so it most certainly can get into breast milk. There's high inter-individual variability, and the therapeutic concentrations are pretty variable. In this graph here, or these 2 graphs here on the right, this is from a PK study looking at sertraline and DMS concentrations. So sertraline on the top, DMS on the bottom. bottom. And this is looking at maternal plasma, which is in the dark circles, and maternal breast milk in the white circles, and then total cumulative exposure in the triangles. And you can see here that both of them peak kind of around that 5 to 6 time frame, but they do maintain in detectable levels in the blood over about the course of 24 hours. And knowing this, in moms, we still haven't really adequately characterized the PK in infants. And in addition to trying to do this, thinking about it just in general, we most certainly need to do this over time. So we know that SSRIs, even when started, particularly in the postnatal period, about 30% of moms who are on them in the postnatal period may be on them, 3 years later. So this is something not that we're doing just in one period of time. Take oxycodone that we were talking about earlier, which is a pretty narrow time frame. This is something much longer. For those who have breastfed or taken care of babies who are receiving this milk, we know that it changes from colostrum to mature milk. This graph shows the difference in protein, fat, lactose, the actual total volume that's changing over time. And so how do the physicochemical properties of sertraline, the makeup of milk, affect how much drug is getting into the milk and how much drug is getting into the baby? So a couple of the gaps of knowledge that I think we've defined is that we know that sertraline is effective for the treatment of depressive disorder, but effects on the infant are unknown. The maternal PK properties of sertraline, seeing that it lasts in blood for a long time and the peaks are variable, really prevents moms from saying we can pump and dump after a dose, and hard to know if we can breastfeed around dosing. We don't know how much is getting into infants, and that this human milk composition and infant feed volume change over time. And so how is that going to affect how much drug the babies are seeing over time? And a couple of challenges of filling these gaps that I think this conference has laid out really nicely, and prevents us from enrolling these moms and infants into maybe more typical trials is the potential exposure of infant to an unstudied drug. And I think that's what's nice about the Cuddle study and more of these standard of care trials, that these moms are already taking it. There's high inter-individual variability. Some moms may be reluctant to consent. And then the time and money required to collect these samples. So early on, these moms and babies might be going to the clinic frequently and so have more interface with physicians and maybe research coordinators, but as they get older and are coming into less to the clinic, it might be harder to be able to engage these families. We know that breast milk is liquid gold, so taking a tiny amount of colostrum might be a big deal in a mom who's struggling to breastfeed. And then, if you're trying to get blood from a baby, a lot of moms aren't going to want their kids to get a heel prick, but how can we work with families to do that? And then lastly, and again, I'm glad that we're talking about this, is the lack of trained clinical researchers with expertise to design and interpret these trials. So some of the things that people in general have been thinking about that I think that he made this more accessible, and I should say put vulnerable populations here in quotes. But one of the research methodologies that interests me is population pharmacokinetic modeling and simulation to really try to narrow down sample sizes, identify variability, doing opportunistic study, and I'll say air quotes vulnerable populations, but these patients who are already taking these drugs per standard of care, who are getting lab draws for other reasons, that maybe we can take extra blood from that. And then this at-home data collection, which I'll get to a little bit in our methods. So with all of that, the overall objective for our project was to evaluate a systematic approach for quantifying drug transfer into breast milk over time using novel collection methods to provide guidance for safe breastfeeding during maternal drug therapy. And again, we're using sertraline as essentially a probe drug for this, but hope to be able to expand it as well. And so for this, we're using 2 study cohorts. The Pediatric Trials Network, we've heard about the Cuddle study. Just to reemphasize that, this is clinically collected human milk and maternal and infant plasma. So this, we'll say, is kind of like the traditional standard of care collection. We right now have 34 paired samples and additionally more samples of mothers and infants that are not all at the paired time. And this is really focusing on the first 6 months postpartum. And then through the MPRINT Center of Excellence at UCSD and Dr. Chambers' Mommy's Milk Human Milk Research Biorepository, we've been able to get this additional cohort that's looking at blood and milk that's been collected at home. So human milk from home, and then infant and maternal dried blood spots, which again are collected at home. We have 26 paired samples, additional ones from mothers and infants that are unpaired. And this is looking a lot longer, really in the first 2 years of life. And again, these are all women that are taking sertraline per standard of care. So the aims for this were to estimate sertraline and desmethylsertraline exposure parameters in all of these paired samples using those collected at home collected traditionally in the clinic and at home. Second, to perform a comparability analysis to figure out if there are any correction factors needed, and then be able to combine all of those samples to develop a population PK model and explore some of the covariates that are associated with changes to drug transfer over time. So starting with AIM-1, this is just a little schematic looking at, again, the human milk biorepository has this at-home collected milk as well as dried blood spots from both the mom and the baby collected over the course of birth to 24 months. And then looking at the Cuddle study, which has maternal milk as well as clinic collected plasma. And we'll be able to calculate these exposure parameters listed here on the right side for each study separately. And then in the second part, or the second aim of this study, we'll do a comparability analysis. So in this table here at the top, we'll be able to stratify the collections that we have in between the human milk biorepository samples and the PTN samples, and then analyze them using linear regression and mixed effects modeling down here with this graph on the left, and try to figure out what correction factor is needed. So this graph here is from a different study that our group did in ampicillin, comparing plasma and dried blood spots. And we essentially were able to see, quantify what that correction factor is, add that to the dried blood spot samples, and then combine all the data. And we'll evaluate bias using Bland-Altman plots. And then I know a lot of us in the room are familiar with population PK models, but just to take a step back for those who are not, I think this methodology is really nice for when we can't enroll robust, standard typical PK trials. So these mothers here, each individual mom who is taking a medication per standard of care, rather than having to have fixed doses and really robust sampling, we could collect a sample or two from each of those women as well as their covariates, combine them all into one model over time, be able to quantify or characterize the drug exposure in the population, and then take that back to each individual to predict what her exposures would be. So this is just a nice way that we've done in pediatrics that I think could work in this situation as well, both for the mom and for the breast milk and for the baby. And so with the population PK model, we'll develop that in non-mem. We'll evaluate a couple of different structural components. We'll evaluate covariates as well. And this down here is just looking at the overall PK structure. So like I mentioned before, we're looking at the three different steps. So we have to look at what's getting into mom's blood. We then have to look at what's getting into the breast milk, and that's denoted here by the human milk compartment. And then we also need to look at what's getting into the infant plasma. And so for the future impact of this, again, I wish I had some data to share with you guys today, but we're still working on it. I hope we'll, one, be able to provide the data for the safe and effective use of sertraline during breastfeeding. And I think another important role of this study is to really validate this at-home sample collection that makes it more feasible for more families to be participating in research, to follow these families over time, and expand out where we have this data from. And then, like I mentioned earlier, hopefully expand this to other models. And I do think this is an important way that we can encourage collaboration between networks like the Pediatric Trials Network, between MPRINT Hub, between UCSD and other places that are all doing really important work. So just wanted to say thank you to the couple of the people here, and I'm happy to take any questions.
Hi, great presentation. I'm Laura Ramsey from Children's Mercy. I was wondering, you mentioned that there are some CYP enzymes that metabolize sertraline. I was wondering if you're planning on doing pharmacogenetic testing and taking that into account in your PK modeling.
It's a great question. For this project in particular, no. I do think there are definitely ways that we could incorporate in the future. I know Vanderbilt does a lot of genomic research there, and so I do think that would be nice to have eventually. For this model right now, unfortunately not, but I do hope one day we can. Yeah, I think we do have it. Oh, we have it in the samples, yes. Yeah, so we'll explore it.
General question.
Yes.
Your study and all these studies require bioanalytical method validation. And so when you're doing your long-term, short-term stability, what are you using? How are you acquiring your blank human milk? Are you getting it early in pregnancy, late in pregnancy? Is it derived from the same studies or from a separate study? Can you talk about that?
That's a good question. And Dr. Greenberg, I might punt to you on this as well. But I know a lot of the Pediatric Trials Network does method sharing. And so if they have developed assays for different drugs that they've used, they'll share that without having to go through the cost of developing all these assays. And then for the breast milk ones, they are validated per FDA guidance, but I don't know if you have anything else to add for that.
No, but stability is an important question, and part of one of the reasons I think, we have a little bit more control in prospective studies in terms of how samples are handled versus registry. And that's, I think, part of the motivation in doing your comparability analysis is see what are we seeing? Are we seeing a lot more variability in, the registry samples and when we're looking at the drugs or maybe not, or does it depend on the drug? So it's a great point.
Thank you.
Thank you. Alamika Fletcher from FDA. Very interesting work. I'm wondering how much are you capturing the different conditions, to follow up into Raman's question, for the actual sample collection? And are there any evaluations of the sampling methods outside of this population in terms of how well, let's say, the DBS has been done for sertraline in other settings where maybe you would have richer data?
Yeah, so I'm not familiar on the data in sertraline in particular, but there are other drugs where we've done comparability studies looking at dried blood samples versus plasma. And so I think the methodology there is pretty sound. And I think that's why we want to do this study, so we can say at different time points, at different time after dose, at different time after feed, comparing infant volumes, things like that. Are we able to compare? So I think the methodology has most certainly been done before, and this is the data that we need. So I think it's a little bit novel in that aspect.
Great. Well, we are, for our last 10 minutes here, we're open for a panel discussion and happy to take any additional questions or comments from the audience. And then we'll go to the survey questions.
Yeah, so this is actually an online question from a participant. The FDA talked about the summary statement in the PREG-LAC labeling PLR label recommendations. The question was, first, is there thoughts on providing a true lay summary for individuals? And then following up on that, after Rachel talked, they sent, PTN says it will be available on the website. Why having duplication and why not? Is that something you could work with the FDA to include?
So if I'm understanding the question, can we provide information that's presented in lay terms for patients in FDA labeling? So there are things called medication guides, and there are prescriber information at the end of the labeling that we do try to put into lay terms. Part of what we have to work within is our framework for labeling, which we have all these regulations that we have to follow in terms of what can be included and what can't. But within that context, we are trying to make it clearer and using lay language, although I would argue that a lot of the information we have is not, understandable to most lay people. But that's, it's prescriber information so we have patient information and we have prescriber information. So to the extent that we can make sure at the time that PTN is submitting the information that we get it in as patient-friendly as possible, I think is what we could do.
Yeah, I think it's somewhat a matter of who the audience is for the package insert versus the audience, how we really expect to reach the end users. And kind of coming back to what Dr. Lewis was saying earlier, we have to be creative about that. So yes, I think there are a lot of regulations, a lot of approvals that have to go into place both from the regulatory bodies, from the NDA holders. Everyone has to agree on the things that go in there, but and that takes a ton of time. I mean, months and months and months of work to get to that. But could we? I think there's the lay summaries, or what we call results at a glance, or other methods that could be done, like, you know, whether it's the TikTok or anything else, you know, they probably don't need that level of scrutiny in terms of what the language is. And so maybe, you know, you'd be trying to get agreement where agreement's not needed. So I think honestly, the thing to do is put the information into as many hands as possible. And probably the most expedient way we can do that is the way we need to do it.
That reminded me that I think that Rachel's right on that. I don't think it's duplication. I would argue that it's getting in as many forms as possible so that we reach as many of the people who need to know this. So maybe FDA labeling is more sort of for the prescriber, but there are other ways that that information can be distilled that would be helpful to the patient.
Thanks. All right, I'm going to go to what the survey responses were. So we asked the question about what are pressing gaps, and the responses were ones that I think you already addressed: lack of data availability, sharing across sites, access to patients. But one question was on preterm milk. So oftentimes this comes up in LACT-Med, where, you know, the recommendation or the information may say, you know, we're not concerned about this drug, but we really don't know about gut integrity in a preterm infant, and this may be a higher risk population. We really need data in that space. So I'm wondering if any of you can comment on is this truly a gap and how it's being addressed?
Well, as the neonatologist in the group, I can take the first stab. I think you know, it is desperately needed, and that, you know, I think we all recognize the benefits of breast milk for all infants and mothers, but in particular the premature infant population. That's where the most of the data are around actually making a difference in long-term outcome. You know, in particular this question of gut integrity. And we do collect gestational age as part of the Cuddle study. And so, you know, there are probably, you know, secondary analyses that they can be done, but the premature population is such a, you know, it's a fraction of the term population. And so we just don't have the data, but I think that's where the registries can come into play, because then as time goes by, if lots of people are contributing to these registries, you get more and more information. But I agree. It's definitely needed. Not everything in terms of safety is that's found in the term population is going to apply to the preterm population. I mean, and then there are other things that are maybe less important. Like, am I, you know, in terms of like oxycodone, give the example, am I as concerned maybe with like the effects of potential effects of sedation on a, you know, 25-week infant? Maybe not, but I'm more concerned with gut integrity. And so the questions of safety are different for the premature population. Is a really important point.
So the simple answer is yes, it's a knowledge gap. And I do wonder if there are ways, you know, the premature infant is, you know, the developing premature infant has sort of certain physiologic differences that we know about. So if we had the data in, let's say, full-term infants, and we had some data, even limited, sampling in the preterm infant for those same drugs, is there a way to develop these PBPK models that could help us then extrapolate once we get information? I think that's one area that could be explored.
Liz is doing that for her next project.
Yeah, I definitely agree, because I think, you know, there's some literature about organ development in these preterm populations. And if you can incorporate that into a model, it can significantly limit the amount of samples that you need to be able to make some meaningful conclusions.
Thanks. The other question that we posed to the survey responders was, are there new technologies or techniques that could be applied in this space? And we got a number of suggestions. One is interoperable informatics, longitudinal studies, linked participant IDs. I would comment there, if this is talking about EHRs, how important it is to have breastfeeding information in the EHR for that actually tells you what the mother's taking and what the infant's getting, which is not standard in EHRs. Microbiome omics, casting a wide net, as Shirley spoke to, a master protocol design, sustainable research infrastructure, and then exploring dried milk spots as a sampling technique. I don't know if any of you can comment on that.
I can't. I don't know of studies that are exploring that, but an interesting thought for sure. I mean, I think Liz presented some of the utility of dried blood spots and that we found. We've also found in some pretty considerable variability even in dried blood spots in terms of the samples and the correction factor. So if it's feasible, I think people are used to collecting and potentially freezing breast milk. So maybe but then, the handling and everything like that, it can be more challenging. So, I mean, I think that's potentially an area for future study. There probably are studies out there if it's coming up, but I just am not aware of them.
All right. And one last question we got it. Question.
Actually, Izzy, that one thing is really more for an IRB. They realized we talked about that when a woman gets pregnant in a study, in general, the drug is stopped. But it made me realize as an ex-IRB person and as part of the DSMB that we really need that in consent forms. I mean, we need to inform adults who are in a study who could get pregnant what's going to happen if they get pregnant. I mean, that seems to me that we can't just say the study will stop, which is what we do now. That's not enough. And I think that needs to change. The other thing second thing is a question to the FDA probably, but it came up from VPCA studies. And I don't know if there's anything to be done about it, but one other thing I didn't realize is that when you do an important study, an off-label drug, when that drug is now being manufactured by multiple manufacturers, every one of them has to approve any label change before any of them can change their label. And that has been a major holdup in these label changes. And I wonder if either Rachel or the FDA wants to comment. Is there anything that can be done to deal with that frustrating last manufacturer who doesn't want to approve a label change?
Well, I can speak and maybe Rachel can add, but so the law is pretty specific about, how we make the labeling changes under the NIH BPCA program. And what we do is we send it to the person who, what we call the reference listed drug holder. So that's the person who kind of owns the labeling, and then all generics. And a lot of times, amoxicillin, there's a lot of generics, right? And we send it to all of them and we say, here, you need to change your labeling. If there's a holdout, the one stick that we do have, and we haven't had to do it because most of the time, once we say that, they'll go ahead and change. The generics, I haven't heard as much of a problem necessarily because generic manufacturers know their labeling has to be exactly the same. There's no room to make a difference, very limited differences. But if there's a holdout, one of the things that the law gives us is that if you disagree with the labeling change, we can take you to an advisory committee. Most of these companies do not want to have to go to an advisory committee convened by FDA. So once they hear that, then most of the time we can get it. That's not to say that it doesn't take a long time to send out those labeling requests, to get all the labeling requests back, and then to show that the information is changed. So your point's well taken. I don't know. We haven't figured out how to speed up that process, but I think we should probably take a look at that.
It's a monumental effort in tracking as well in terms of because one hold up in the process can slow things down. I mean, and some of it is we encountered with one of our molecules that recently got a label change. One of the manufacturers, wanted to review all the data and also do the analyses. And it's almost like the single IRB and the local IRBs. Like, at some point, like someone's got to start trusting the authority to on what's correct. But I understand the implications and the risks from the company perspective in making some of these updates. And that's why it takes patience and it takes investment in a program that can do this longitudinally. Like this is not a 2-year grant this is like, an investment in sometimes 10 years of work to get a label or more to get a label update. So, this is a hugely important piece of legislation that's led us to be able to try to work through it. But I agree. I think I think each one, we learn more and more about the process. There's a lot of, process stuff that has actually gotten better over time. And thanks to FDA, the people that are, within this program that are very passionate about seeing it get done.
One thought, and Rachel, maybe you've thought of this before, but as you add new drugs, I wonder if the various generic and innovator manufacturers are aware you've added that drug and that within a few years, you're going to have your 50 and you're going to be introducing hopefully a label change. So at least it's not surprise at the end of the day.
It's a great question. I don't think right at this point, there are some studies that we've done where we've engaged our industry partners. In particular, sometimes most of our work is in the off-patent space, but when we have an on-patent comparator, there's some utility involving the company in terms of the method or something like that. We've had some industry stakeholder input, but it's not I guess it's not a routine part of what we're doing right now up front, especially with generics and actually in the landscape changes over time in terms of who's currently making it. And, sometimes someone who wasn't making it is now making it again. And then we have to go back and update their label. So it's, even after we thought we were done. So it's a whole different, yeah.
All right, we're going to have to go here in a minute, but I want to ask Shirley one last provocative question. So do you show this really neat association between SSRIs and preterm delivery and changes in or different expression of certain parts of the microbiome and oligosaccharides, but it was cross-sectional. So how would you design the study that would have to follow on that to actually say that this may be some intervening factor following SSRI or depression exposure, which we know is associated with preterm delivery, but it might be in the causal pathway?
Yeah, well, I mean, as we know, prospective randomized trials are the gold standard. And so I think our study at least, took advantage of samples that already existed and we found some potential mechanisms that might be going on. So, designing a prospective study of women who are on antidepressants and being able to then also look at the breast milk microbiome, the infant microbiome, and the metabolome would be amazing. And if we could do that longitudinally, get longitudinal samples, because as we know, when we do microbiome studies, everybody has a different microbiome. So being able to do these studies longitudinally is also very powerful. So yes, let's get a study funded that's prospective to look at these very important issues.
Thanks, Shirley. Okay, I want to thank our panel.